Dr. Logli, thank you very much for joining us. Appreciate you taking the time out of your busy clinic schedule and a Monday.
Thank you so much, Bill, for the introduction, and thank you all for joining me today on a topic that I feel very passionate about. It's a topic that I feel like I've had an opportunity to have a value add, especially for the injured worker. And I'll be talking today about carpal tunnel syndrome, of course, and some new techniques, including ultrasound-guided release of the carpal tunnel, which its value to the injured worker is really just getting them back to work sooner. And we always mention this, but this technique is brought to us largely by some innovation and technology from a company, but I am not, I don't receive any remuneration from that company. And just wanted to share a little bit about myself. This is my first time, I think I'm meeting many of you, at least virtually. And on the left are a bunch of institutions that I've been proud enough to be associated with. And then my family who's helped me get through all those institutions along the way. I showed this slide previously, and someone thought that meant I had worked at McDonald's, but that just represents Des Plaines, Illinois, which is the first McDonald's, the one few thing that we're known for. This is where I practice in Algonquin, Illinois on Randall Road, and we also have an office just south of this. The procedure I'm going to be talking about later, I offer to workers at both locations. And then I'm also assisted by my physician assistant, Adalia Zahara. She has been a huge asset to our team, and patients love her. And the added benefit of having her on the team is she's fluent in Polish and Spanish, and some of my injured workers are bilingual, and it helps to have someone on the team that they can speak directly to them in their native language. So let's dive in just with the background knowledge and understanding of carpal tunnel syndrome and what we're talking about today. So everyone knows carpal tunnel syndrome is one of the most common conditions, and it affects probably more people than we really can appreciate, but 13 million people in the United States at least is one statistic. And what is it exactly? It's when the median nerve, so a single nerve that provides motor function and sensation to the hand, is pinched, compressed, under pressure, right where the wrist meets the hand. Just hold up my hand here, but kind of right at the skin crease right here is typically where the nerve enters the carpal tunnel. And this is where we see some compression and where we can elicit some signs on examination. It is a physical tunnel, and there's a cross section on the bottom of the image there, which kind of shows all the structures that go through the tunnel. So it's not just the nerve, but also a lot of the tendons that bend the fingers. And so if you think about a lot of repetitive activity and things that patients or workers do, a lot of repetitive type activities where those tendons are constantly firing are kind of rubbing up against that nerve and could irritate and bother the nerve. And so what do people feel when they have carpal tunnel syndrome? It's predominantly symptoms in the thumb, the index finger, the middle finger, and then half of the ring finger. People endorse painful burning, numbness and tingling. Some report nerve symptoms or pins and needles. They also sometimes get forearm tenderness and pain radiating up the arm. Even though it's not a classic symptom and something that we can't necessarily tie necessarily to anatomy, we do see it routinely. It's going up to the elbow, sometimes going up to the shoulder, and then they get weakness of grip. They start dropping things. Some of it's because they actually are getting weaker, and some of it's just because of the pain that they feel when they're trying to grip hard. The dark orange portions of this picture are where people typically feel carpal tunnel symptoms when they occur. And there can be some overlaps with things such as a cervical radiculopathy, a pinched nerve in the neck, or a pinched nerve in another part of the arm. And so what causes carpal tunnel syndrome? Multiple causes. We consider it consider multiple factors, multifactorial, but repetitive use of the hands, exposure to vibrations through power tools or certain industry type equipment, or direct trauma. We've seen it in car accidents or a fall onto a wrist. It can be associated with a fracture of the wrist or completely unassociated with a fracture of the wrist. And so think about patients in assembly lines, typing, power tool use, machine operation, or when they actually have, like I said, a wrist fracture. And then there's also some other medical conditions that can be associated with it, where the kind of work site activity could aggravate some of their pre-existing conditions or predisposition. Specifically for the workplace risk factors, we're thinking about high repetitive activities. We're thinking about forceful and repetitive gripping, and also poor ergonomics. So some of these symptoms, especially early on, can be adjusted through workplace modifications. So again, carpal tunnel complaints. So what do sometimes patients come to me saying? They'll say they shake out their hand. They're after a long day of work, or while they're using a tool, they'll have to stop and kind of actually physically shake out their hand. That's actually a positive sign that we report in the medical literature, where it's called the shake sign. They get achiness or stiffness, sometimes in the mornings, sometimes after a long shift, 8 or 10 hours. Disruption of their sleep. They'll wake up in the middle of the night with numbness and tingling in their hand. They'll again want to shake out their hand, or first thing in the morning. Everything just won't be feeling like they can make a tight fist, like they can grip tightly. Sometimes there'll be issues with driving. So I have truck drivers and people that drive a machine or a truck back and forth to work, who are constantly complaining of this type of symptom. They'll be dropping things. They have weakness and tiredness in the hand. And this is what I try to emphasize to patients, that if carpal tunnel syndrome symptoms progress, if they don't get adequately treated, if there's a delay in diagnosis, which a lot of you can help getting the diagnosis addressed early on, or if they just neglect those symptoms, the carpal tunnel symptoms can progress, and what that can lead to is permanent nerve injury, which leads to permanent numbness, weakness, tingling in the hands, and also muscle loss. And a lot of times we have patients report that, I had a carpal tunnel release, but I had a poor outcome. And oftentimes that poor outcome is just as a result of when they had the surgery done. It's only as good as the quality of the nerve and how many axons or small nerve cells are still present by the time we do the surgery. And so how do we diagnose these things? Our society is very firm on this, that clinical diagnosis is all that is necessary for a diagnosis of carpal tunnel syndrome. And there's certain questionnaires. One of them is a CTS6 that I'll show you on another slide. But it's just asking about some of the symptoms that patients are experiencing. Now, I will say things like ultrasounds and nerve studies can be helpful, and especially in the injured worker, where there might be a little more gray area or difficulty with determining, is this related to a worksite injury, or is it related to something else? Is it coming directly from the carpal tunnel, or is it coming from the neck, for example? And so sometimes we do like these supplemental tests just to further give us, just confirmation that we're treating and addressing the right thing. So this is the example of that CTS6 evaluation tool, and it asks about a lot of the symptoms we discussed, and each of those symptoms gets a number, a numerical value, and then we add up that value and determine the probability of those symptoms corresponding to a diagnosis of carpal tunnel syndrome. And this is what our society relies heavily on, is just this. And on the left-hand side are 2 of the physical exam findings that we'll perform. You'll see us document in visits that are quite specific and sensitive for carpal tunnel syndrome. And now here's ultrasound. This is kind of really what I want to emphasize during this talk, and it's one of our key words for today. But a lot of you may be familiar with nerve studies, or what's typically called an EMG. But nowadays, the ultrasound technology is such that we can diagnose carpal tunnel syndrome just by measuring the circumference of the median nerve at the level of the wrist when it enters the carpal tunnel. So that yellow circle there is in this picture, it's a depiction, but I would typically measure that size of the nerve on ultrasound, and I do this at the point of the care with the person in the visit with me. And typically in the literature, it would be a report of carpal tunnel syndrome is when that measures 10 or greater, and that also correlates to a mild, moderate, or severe severity of carpal tunnel syndrome. And so oftentimes we can really avoid invasive and uncomfortable tests for patients, such as a nerve study. And even the American Academy of Orthopedic Surgery currently states that, again, clinical evidence is all that's needed in lieu of these things like ultrasound or nerve conduction studies. However, if there's a choice of a supplemental test, I really like the ultrasound. This is one of my mentors, John Fowler at the University of Pittsburgh. He wrote this article in the Journal of Bone and Joint Surgery. This is the most cited orthopedic journal there is. So it's a high level of evidence, a high amount of readership here. And they discuss how ultrasound is the most specific, actually, for the diagnosis of carpal tunnel syndrome when compared to nerve conduction studies for carpal tunnel syndrome. So now we talked about diagnosis. How do we manage these? Almost everyone, regardless of how frequently their symptoms have been present or how severe their symptoms are, I really give them a trial of nonoperative management, which consists of nighttime immobilization and modification of activity. The modification of activity is really kind of reduction in repetitive grasping, gripping. It's kind of those ergonomic workplace modifications that may take pressure off of the front of the wrist. And then nighttime immobilization is by far the tried and true, and it's the one that has the best evidence behind it, the one treatment that has the best evidence behind it. And it's as simple as a wrist brace that you wear to sleep only at nighttime. There are some other things. Physical therapy, perform nerve gliding exercises are supposed to induce a little bit more motion around the nerve. It gets the tendons gliding next to the nerve. We looked at that picture of all the tendons and the nerve in the tunnel together. And so the thought here is that almost kind of like we're lubricating the nerve with our motion. I do try this, especially if it's an early symptom or if the symptoms are mild. But overall, if the symptoms are any more than that, we really kind of go on to the bracing. And the reason because that is because, there's been studies that have shown that nerve gliding exercises plus a brace alone is really no better than the brace. So the nerve gliding exercises may be supplemental, maybe something to give a patient to kind of focus on or to feel like they're contributing to the resolution of their symptoms. But really the brace kind of does the majority of the work. People ask me about injections all the time. I do perform injections, but I would say it's becoming less and less frequent, and it's only for really specific indications. I will say of my patients that I perform injections on, it's more common in the injured worker, and the reason is because, again, there are sometimes differences with history reported, or it's not necessarily clear that it's a clear and cut case of carpal tunnel syndrome. And what I tell patients is that we're performing an injection for both diagnostic and therapeutic purposes. So I hope that the injection helps you. I hope it relieves your pain, your numbness, your tingling, your burning. But really, I'm also doing this to help me with the diagnosis, to say, like, if you got better, then we know that whatever percentage you get better, that's how much of your symptoms are coming from carpal tunnel syndrome. The literature would say that the injections are temporary. They are, as patients like to say, a Band-Aid, and they last about 1 to 3 months. If people are 100% normal, they've never had any numbness or tingling, and then they all of a sudden get an injury, and there's some swelling in the area, they immobilize their wrist a little bit, and I think that maybe it's just this, we can get them back to their old baseline by giving them a robust response of steroid in the wrist. And sometimes injections are good in those indications, those circumstances. But with how a lot of providers typically perform these were kind of blind, using anatomic landmarks. And the literature has noted multiple instances of injecting the nerve itself. And so there's an opportunity here to make people worse by injecting their nerve. And that's why I always perform these under ultrasound guidance. Here's an article. Again, this is a systematic review, so it's one of the highest levels of evidence we have, suggesting that a steroid injection is better than a placebo and steroids, but it's not really better than splinting and some really over-the-counter oral anti-inflammatories when you kind of stretch it out over 4 or 8 weeks, and that the effect really declines after a month. And so, especially for the injured worker, when we're trying to get them back to work, if it's a clear-cut diagnosis, I do not typically recommend an injection. We want to get them to feeling better, and we don't want to get them to feeling better not only to come back in our office or come out of the workplace once we get them back to the workplace. And then, the bottom, again, American Academy of Orthopedic Surgery says that there's strong evidence suggesting that steroid injection does not provide long-term improvement in carpal tunnel syndrome. That's a high-quality evidence with a very strong recommendation. So this is less for the injured worker. I've talked on this, so I'm just going to kind of breeze past this, but there's very select indications where I recommend steroid injections nowadays. And so here's kind of what I wanted the bread and butter of the talk, what I wanted to really focus on. There are essentially three broad categories for releasing the carpal tunnel to relieve a lot of these symptoms that we're talking about, some of which you may be aware of already. But there's an open carpal tunnel release, which is in the palm of the hand. It's kind of direct and to the point. We go right through the skin and directly down onto the carpal tunnel and separate the ligament that is putting pressure on the tendon and all the nerves into place. That's what's been done since the 1950s and 1960s. There is a kind of a trend to call the procedure a mini open. This would be a description, a picture rather, of a mini open carpal tunnel incision. The description of that is anything less than 2 centimeters, but essentially it's really no different. It's just an incision right in the front of the palm. Then there's the endoscopic approach. We kind of try to sneak up, so to speak, on the carpal tunnel by approaching it out of the palm of the hand. I performed this technique for a long time, especially for someone like a worker, because it really gets them back a lot sooner. It takes the incision out of the palm of the hand, less soft tissue disruption, and overall a faster recovery. And then there's the ultrasound-guided one. So this is my patient 2 weeks after their ultrasound-guided release. The patient couldn't even identify their surgical incision. We don't use sutures to close it. We don't even glue it shut. It's just stripped in place. And the benefit of this here, and as we've seen with time, is that the smaller the incision, the smaller we can disrupt the surrounding anatomy, the faster the return to normal activity. And for the worker, that's huge. That's getting them back to the workplace doing what they normally do. So again, we're kind of just emphasizing this is what the open surgery looks like. It's going down right to the point, transecting the ligament to relieve the pressure on the nerve that lies directly below it. This is an example of an endoscopic procedure. On the right, you see an image. This is taken from my operating room. I'm looking up at the ligament. All the surrounding important anatomy is around me. You can see that I can't see any of it. I just know that it's not where I'm doing the work. And the work is there's a blade at the end of that cannula, and I reach up, I cut the ligament, and I slowly drag it back. And so on the left, you see me starting to make that cut. On the right, you see fat. That's fat in the palm of the hand after I know it's completely released. But still, again, I'm going to emphasize that I know that I'm not cutting anything around me, but I know that by it not being where I'm doing the work. Whereas what I'm talking about now is ultrasound-guided carpal tunnel release. And this is a way for me to actually see more anatomy through a less invasive approach. On the right side is a picture of what this looks like in my office. This is a patient wide awake in their street clothes coming in. They're signing in for an appointment. I see them within 5 to 10 minutes. We lie them down. They get to pick the music they want to listen to. Their hand is outstretched on the table. And I start by just scanning the wrist. It's just ultrasound jelly and an ultrasound probe. It's not painful in any way. Ultimately, we release the carpal tunnel using a device that's on the left of the screen. It's a smaller device than most endoscopic devices. It has a blade on the end of it, and it has numerous safety features to kind of push away the surrounding anatomy as I watch it and do the procedure. You can also see that we do not have to do this in the operating room. I do not do this in the operating room, which is huge cost savings. And I use very few instruments. That table on the left is all that I need to perform this procedure. This is a depiction of what I see in the surrounding anatomy while I'm performing this procedure, also with colors to kind of make it very simple. But the structure in white that looks like a spaceship is what I see representing the device in the wrist. The nerve is in yellow, and the ligament is in orange that I end up cutting. You can see things such as the ulnar artery. You could see the bony anatomy, like such as the hook of the hamate there on the side. And you can see all the tendons clearly. Even things that MRI can't pick up on, I can see with the ultrasound. And, is this safe? Is this effective? We know that this has been around since the early 2000s, and so far, everything has been as safe and as effective as the endoscopic and open carpal tunnel releases approach, with faster recovery, smaller incisions, less soft tissue disruption. And so this is a study, numerous institutions, Washington University in St. Louis, Harvard, getting together to form a randomized controlled trial looking at ultrasound-guided release versus mini open release. And this study demonstrated that even with less surgical experience, because it's a newer technique, that it's equal efficacy and safety. And a faster return to work. So this is one of my mentors, Alexander Shin from the Mayo Clinic. I was exposed to this while I was in training there for orthopedic residency, and slightly different technique, but using ultrasound guidance through very small incisions. And what they found was that people were getting back to work a lot faster. So this is my incision 5 to 7 days post-operatively. It is a little bit of red. And the skin edges are maybe slightly irritated, but that's it. And again, this is no stitches, this is no glue. Their bandage just fell off. And at this point, at 5 to 7 days, I return them to full duty. The literature supporting the ultrasound carpal tunnel release suggests that you can go back to work in 3 to 6 days. And that is not just a greeter at the front of a convenience store. This is my plumbers, my diesel mechanics, my laborers, construction workers, concrete, everything. It's hard to give a guarantee, but I would say 95% of people are back to work in 2 weeks or less. Another example, I changed the direction of this incision, but very small, 5 to 7 days. And this is the one I showed previously. My keyword here at the bottom of the screen is safe for those of you who need that. And this patient was thrilled with the result. So my experience so far with the ultrasound-guided carpal tunnel release, both in my own institution and when I was practicing and training orthopedic residency and a fellowship, smaller incision. There's less pillar pain. So pillar pain is what people actually, we can't get rid of it completely, but there's less of it. And that's just pain kind of right in the palm where that ligament is cut. We think that by detensioning the ligament that it potentially caused some of the discomfort and pain. Less need for therapy. Sometimes the worker is a little bit unique in this instance, and they want a little more hands-on, more scar massage and things of that nature. But I really strive to keep them away from therapy after this procedure because they simply don't need it. Faster recovery, high patient satisfaction. There's a high patient interest, so I have a lot of them kind of leaning over to like look at the ultrasound machine and kind of see what I'm doing. And lower morbidity when a bilateral procedure. So this is the only procedure out there from an open versus endoscopic that I will perform bilateral routinely. And that's just because they get back so much faster and they don't have to stage them and be away from work or activities or hobbies for just that much longer. And then local only, I don't use any type of tourniquet. I don't have them hold any blood thinning medications or any other medications. And so, a lot of things in the pro category. Compared to endoscopic, I actually think it's better visualization, even though I'm using an ultrasound instead of an actual camera. Faster recovery and return to work, even than my endoscopic patients. My endoscopic patients are probably returning to work 3 to 6 weeks, and this, like I said, is less than 2. Comfort and convenience, they really like just coming in the office as if they're coming for an appointment instead of going to the operating room, getting into a gown, having their blood pressure taken. All of what we know is associated with having a procedure done in a surgery center. And then compared to open, without a doubt, there's just less wound healing issues, less surgical site infections, less pillar pain. So a huge difference when compared to the open technique. This is someone, I asked them to take a picture of their hand when they came in. Grease embedded in every crease possible in their hand. And this is the patient who, previously I was performing an endoscopic carpal tunnel release on because we're away from the palm of the hand. But even more so, the opportunity to try to reduce soft tissue disruption, reduce the size of the incision. So right now, the ultrasound technique is really my preferred technique for laborers, anyone who has thick calluses on their hands and dirty palms, heavy loads on the palms, because it just gets them back sooner. I also have people that maybe a different population, but who use a gait aid, or maybe they have to care for a loved one, and it really just gets that incision out of the palm of the hand. So again, benefits of carpal tunnel release with ultrasound guidance. I've harped on some of this before, but just to emphasize again, no preoperative clearance, so reduces the cost and time associated with all of those things, seeing a medical provider, primary care provider, having an EKG done, getting blood work done. Patients don't like that and delays care. We don't have to hold medication, blood thinners. We don't hold Eliquis, warfarin, anyone you could name. I don't hold it. Bleeding is so minimal in this procedure, and I use epinephrine in my local anesthesia to really act locally as a hemostatic effect. It's local only anesthesia, so the patients are wide awake. They love that. They drive themselves home. The only people I recommend they have a ride is if I do both at the same day because their hands are numb when they leave. No stitches, so no suture abscesses or irritation, no thick scar. I give them a waterproof dressing, no splints. They go home the same day. They can shower that night. They can wash their hand that same night. No narcotic pain medications. And this is not because I'm cruel. This is because they simply don't need it. Ibuprofen and Tylenol, as long as they could take those two things, that's pretty much it. In-office convenience, we talked about that. No postoperative therapy. And the most patients, 3 to 6 days. If they're really heavy laborers, I usually give them a week off, and then I return them to work at that second week. And so this is some testimonials I've received from patients. The top one, I had surgery on a Friday. I was back to work on Monday. There was no recovery. Within 2 days, I was back to doing normal stuff. It was really that easy. And then I actually went to my site and I took my most recent review about this procedure. This patient I did Wednesday last week, and he wrote this review on Thursday. Best and easiest operation I've ever had. I would recommend this doctor in a heartbeat. I came 200 miles for this wonderful operation. And he's a truck driver. He's been driving a truck for 45 years and was very thrilled by the incision. This is not his incision on the bottom, but this is an example. And so thank you. I know I'm early. I apologize for that. But I hope I was able to kind of emphasize why I think this is really helpful in the area of carpal tunnel syndrome, which is very common for the injured worker, and how we could just get them back to work faster.
If you have any other questions about workers' compensation, referrals, or to learn more about our Fast Track program for injured workers, please see our website, OrthoIllinois.com, and click on Employers. In Algonquin, Elgin, McHenry, and the greater Chicagoland area, call Paul Strandquist at 815-847-7088. And for Rockford, North Central Illinois, and Southern Wisconsin, call me, Bill Collar, 815-847-7044. I had questions about when you are looking and diagnosing carpal tunnel under ultrasound. What is it specifically that you were looking for? Can you actually visualize the compression of the median nerve, or what is it that you're looking for when you're diagnosing via ultrasound?
Yeah, so it's a great question. So what we typically look for is we just really measure the circumference of the nerve. So what's the size of the nerve? And we compare it to standard norms. What studies on ultrasound evaluation of carpal tunnel syndrome has determined is that anyone with a cross-sectional area measured on ultrasound of the median nerve at the carpal tunnel inlet, so right at the edge of the skin crease there as the wrist meets the palm, of 10 millimeters squared or more is consistent with carpal tunnel syndrome. So we don't see really anything other than we measure the size of the nerve. In a normal person, a person without carpal tunnel symptoms, their nerve is going to be smaller than that. And the analogy I like to use for patients is almost if you step on a garden hose, you would expect the garden hose in front of your foot to start to swell, and then all the fluid on the other end of your foot to kind of get smaller, and that's what we see. So the nerve being compressed at the carpal tunnel actually starts to swell. And we actually do see after a carpal tunnel release, some of that swelling go down. And so, or after an injection or after treatment with a brace, we see the swelling go down. And so 10 millimeters squared or more is consistent with a diagnosis of carpal tunnel syndrome. We also have a severity criteria. So 10 to 12 is considered mild, 12 to 14 is moderate, and greater than 14 is considered severe.
Excellent. What do you think? Now, I know you mentioned this a little bit. On average, what do you think the return to work with an ultrasound-guided carpal tunnel release is compared to open and endoscopic?
Yeah, so for my patients who are an open carpal tunnel release, they have more physical signs of a surgery. And so I feel like that also holds them back. If you asked how soon could they possibly go back to work and not cause any injury to themselves, not aggravate anything, it's probably a lot sooner than we tell them. But again, patients with an open carpal tunnel release, they have a larger incision, they have some sensitivity in the palm and more swelling. And so my patients, especially workers with workers insurance, are probably going back to work full duty at about 8 to 12 weeks. My endoscopic carpal tunnels are about 4 to 6 weeks, and so far all the ultrasounds are less than 2 weeks.
So I've been here at OrthoIllinois now for almost 18 years, and it wasn't that long ago. The standard of care was a plaster splint following carpal tunnel surgery as well for at least a week.
Yeah.
And none of that with ultrasound is necessary. They walk out with a Band-Aid on or a steri strip, I think.
That's right. So we do a steri strip over the surgical incision, and then we put a little piece of gauze and a piece of Tegaderm. So it's like a transparent film with a watertight seal, so they can immediately wash their hands, get off all the procedural prep, and start taking showers right away. No splints at all.
How about complication revision rates, in comparison between those three procedures that you detailed?
So the device that I use currently was FDA approved in 2019. So we don't have long-term data greater than 10 years on that device. Ultrasound-guided release procedures have been around since the early 2000s. So we're starting to get that long-term data. So far, the midterm or medium-term data would suggest that from a revision rate, it's about equivalent to open and endoscopic. And from an infection or complication standpoint, it's probably equivalent to the open and slightly lower than endoscopic. There are some studies that endoscopic has a higher rate of complications. A variety of reasons for that, but generally speaking, ultrasound is lower or equal to these other options.
Of course, with I don't want to say a newer procedure, because you said this has been around since the early 2000s, but cost is always a concern. When you compare those three, how do the costs compare between the different surgeries?
So some early adopters of this have done cost analyses, and the device is more expensive than the endoscopic devices, and certainly more expensive than a scalpel is to do an open procedure. But if you look at the total cost of care, and also the consideration of lost time from work, there's a huge advantage to the ultrasound-guided option. You don't have to do it in a surgical setting or a hospital. You don't have as many follow-up visits. You don't have physical therapy visits, and you're returning to work faster. So on all ends of this, on the payer, on the patient side, on the provider side, it's a faster, more streamlined process with a quicker turnaround.
And when I saw your slide with the greasy palm, which, I mean, we see a lot of those hard laborers, that is how they come in.
Right.
How about wound complications between those three? Obviously, if you have a heavy laborer working in a foundry or working in a dirty environment, diesel mechanic is a perfect example of this. The concerns for wound complications following a traditional open are huge.
Right. Yeah, absolutely. I think, especially anecdotally, I would say open carpal tunnel releases with the sutures in place, especially trying to go back to any type of direct pressure on the palm or holding vibratory tools or any type of friction on the palm. It's a lot harder for them to get over than some of these minimally invasive techniques away from the palm of the hand. And, it seems like such a trivial difference in the ultrasound incision compared to the endoscopic, but the amount that we're able to reduce the soft tissue dissection and disruption has translated into less pain, faster healing, and lower issues of wound healing.
How about FDA approval, peer-reviewed literature, clinical use? What other supportive documentation do you have?
Yeah, so the device I use is, like I said, was FDA approved in 2019, and they're on their second generation of the device. I see that the company continues to grow and are making really good progress. And it's the reason that this isn't more widely talked about is there's a barrier in orthopedic training, because a lot of us don't use ultrasound devices regularly or only use them for select purposes such as injections. And so I think that's the reason why it's not more widely used. I was fortunate enough to kind of train where this was first designed and developed. And so I had hands-on experience early on, and that kind of continued throughout my training. But FDA cleared and approved. And so far, all the data that they have in large randomized studies and multi-center studies suggest that it's equivalent outcomes with open endoscopic as it is ultrasound. I do tell my patients that if the goal is just to remove the symptoms, then really all of them 1 year out, you're going to get the same good outcome, right? We're going to treat the carpal tunnel symptoms. It's really just, the early benefit, getting you back to hobbies faster, getting you back to work faster, getting you back to whatever you want to be doing in life.
I think that, leads into another question that we've got, which is so many people ignore their symptoms or they tough it out. I mean, with this, there are real long-term possible consequences of just trying to power through this, right?
Yeah, absolutely. Like I said, I have many patients who say, I have a friend, I had a coworker who had a carpal tunnel release. They're no better. Their hand is still numb. Their hand is still clumsy. They're dropping things. If there's constant numbness, if there's weakness, if there's atrophy of the thenar muscles, which we see with advanced carpal tunnel syndrome, I tell patients what we can guarantee with the carpal tunnel release is, one, it's not going to get any worse. Number two is anything that comes and goes, I have more numbness. I get more tingling when I sleep, when I drive, when I do my hair, when I'm working with a tool. That gets better quickly. People have report that those symptoms are better within a day or two, but anything that's always there, like my numbs are always numb, and then they get worse when I do this, they get more tingling when I do this. Those things, they can persist. And when we wait to see how much of that nerve recover, but there's a possibility for permanent nerve injury if this is delayed, neglected, ignored. So
what is your typical treatment algorithm look like? When a patient comes in, they've got obvious signs of carpal tunnel. What do those steps look like in general on your average patient?
Yeah, so almost everyone, and there are some people that they've already had a thorough workup. They've already known they've had carpal tunnel syndrome for years. They know they've neglected it. Those people, I'll offer the procedure immediately. But vast majority of people, I would be in the same way. I want to try to do everything possible to avoid anything invasive, which is a procedure or surgery. And so almost everyone, I do a thorough physical exam. We get a history. If it's pretty much clear-cut carpal tunnel syndrome, I give them a nighttime brace. I educate them on how to wear it. And I say that, any type of procedure that we offer you would be essentially like wearing the brace without having to wear the brace. That's what you'll start to appreciate. And so I start the brace. I see him back in 4 weeks. At that 4-week visit, we say, hey, how much better are things? Has it completely eliminated your symptoms? If so, I suppose we could continue to keep it going this way, just wear the nighttime brace. But if at any point in time it worsens, or if the brace no longer manages 100% of the symptoms, then what we're seeing is that the median nerve at the carpal tunnel is irritated, and that irritation can lead to permanent nerve injury. And so we do want to release that. So at 4 weeks, we make a decision. We're either continuing this or the current course with the brace, or we're opting for a surgery.
Dr. Logli, how long have you been doing this ultrasound-guided carpal tunnel release?
So I started with my initial exposure was in residency. So I did a 5-year orthopedic surgery residency at the Mayo Clinic, and one of the co-founders of the company that I used to perform the technique was on staff there at the time and kind of mentored me. And so I started that in my orthopedic surgery training, and then continued that throughout my fellowship. And I've been performing it at OrthoIllinois for just under about a year. So all in all, getting familiar with the ultrasound technique and the carpal tunnel release, it's been about 5 years.
Awesome. Dr. Logli, thank you very much for taking the time to present today. Just so everyone on the call does understand, Dr. Logli did add a surgery unexpectedly this morning and then moved his schedule around and then has this right now. And we've got an event tonight as well to talk a little bit more about this. So he's a busy guy, but he would be more than happy to talk with your patients or you if you have any questions. Again, you can find Dr. Logli on our website at orthoillinois.com. Dr. Logli, have a wonderful day. For everyone on the call, we will give you a little bit of your lunchtime back. And Thanks for joining us for another Ortho Illinois Workers' Comp webinar.
Thank you.